So the really nice thing about the ipi-nivo versus sunitinib study, the 214 study, is that we've just been following these patients for so long. So kudos to the study. They have lost very few people to follow up. We have the data. We have the data on who has progressed and who has gone on to subsequent therapy. We're hoping in the rapid abstract later this afternoon to present it really clearly with investigator-assessed progression, because that was captured more clearly, and show that over the long term, now we're at 8 years, that there are still patients who have not progressed from their initial ipi-nivo therapy and have not required subsequent therapy. Now, it's not the majority of patients. We'll see, it's a small relative minority of patients, but the fact that those patients are there and that we can see them and that we can document them, I think is really critical. How that parlays to where ipi-nivo fits in the whole spectrum is a little tricky, because we just don't have 8-year follow-up data on the IO-TKI combos, but they're hitting every landmark. And they do have the benefit of real short-term benefit in terms of higher overall response rate, better PFS. All the short-term data seem better with the IO-TKIs compared to ipi and nivo. So these are the two things we struggle with. Short-term, it's easier to see quickly, it's easier to compare. Long-term, we really hope all the companies follow the lead of BMS and follow these patients out long-term, because we have the benefit, but also the responsibility of knowing there are patients who will benefit long-term and enjoy treatment-free survival with metastatic renal cell. So one of the really interesting things with this longer-term follow-up of the 214 study with ipi-nivo versus sunitinib is that the results do seem to be pretty consistent. We know we're not seeing new toxicity or new big events later. It does seem to be, if you get past year 5 and 6 to 7 and 8, that those who have not progressed still have not progressed. The dropout is minimal. Again, one interesting thing that I don't think we ever think about in trials is how we think about deaths of patients on study. In the past, they have consistently in the metastatic space been from cancer, and it was safe to assume that. Now, I think we actually need to look at patients who, we see them dying at year 7, 8, and 9. Are they dying of cancer? Are they dying of something else? Because ultimately, in the context of this trial, we'll all die someday, and all patients in the study will also. But if we can let them live their lives cancer-free such that they pass away of something different, that's a cure. So I think a deeper dive into the deaths and how many are from kidney cancer, certainly in the short term they usually are, but in this longer term, are they? We have to ask that question. And this is a great problem to have that I don't think any of us anticipated when we designed the study, that many years ago. So pembrolizumab has been approved for the adjuvant treatment of renal cell carcinoma based on the disease-free survival benefit that was presented last year. So we've been offering it to patients. The conversation has been, we do think this will give you, a chance, double-digit % chance of delaying when you recur. We don't know if it'll prevent it. We hope it will. And now what changes is really the conversation where we say, we don't know if you need treatment at all. You might be cured. If there's cancer still in your body that we can't detect, it might be that this treatment helps eradicate it to let you achieve cure and increase your cure rate. I think we have to be honest that the delta sort of on an absolute basis is small. The other thing we saw in that study is that most patients do very, very well in terms of overall survival. So the control arm, for instance, is performing better than we've ever seen historically. And that's because we have things later for metastatic disease that truthfully improve longevity, like ipi and nivo that we just talked about, looking at the 8-year mark. So we're seeing within these data, the comparison is clear. There's an overall survival benefit. But what's also really nice is that everyone's pretty much doing well in terms of OS, even in this high-risk population. So all of this feeds into how we counsel patients about making a decision about adjuvant therapy. We're already ready to improve adjuvant therapy and see if we can get it to work better. And so there's some personalized vaccine studies ongoing and work that we're participating in at Fox Chase that I think is going to be really, really cool to see if that can even move the needle further. It's really refreshing to see non-clear cell kidney cancer get its sort of moment, that people are interested in studying it and interested in improving treatments for it. The problem we always face is that it's a basket definition of multiple really different biologic entities, particularly chromophobe and papillary are very different from one another. But truthfully, doing these studies all at once is the most efficient way to do them and the best way that we can sort of learn from, again, taking clear cell proven therapies and moving them into non-clear cell. Laurence Albige's study on lenvatinib and pembrolizumab in non-clear cell was really well done. It accrued 93 papillary patients, a really large group. It was single arm, but I think we saw really compelling evidence of overall response rate and sort of progression-free and overall survival in that group that have compelled me to move that to the front line for papillary renal cell. I think we cover the VEGF-TKI pathway with a strong VEGF-TKI, lenvatinib. I think we cover the immunotherapy aspect with pembrolizumab, another strong drug. And then we also can use things like cabozantinib for later. I think there are lots of different ways to do it. Whenever you're using single-arm studies, you're sort of looking study to compare. But the number specifically of papillary patients in that trial, I thought was compelling and made the results robust. RMC was not included in the B61 trial, but chromophobe was. And I think the important thing is whether we include them or as a basket or not, that the therapy be relevant to that disease. And we actually know a lot more about RMC thanks to the work going on at the NCI and at MD Anderson, that the targets are different, the approach is different. We target it more with cytotoxics typically. And so the clinical trials for that disease really don't lend themselves to a basket type of approach leveraging clear cell. And hats off to the folks who are collecting this rare group of patients with this unmet need to really treat this as it is biologically. Chromophobe, I think we've looked a lot into the genomics and biomarkers within that tumor to look for hints as to what might work, and same with papillary. And I think with anything rare, that approach can really bear fruit because you can kind of see biologically what targets might be relevant and then design trials at least with the interventions to help them. But it's helpful for us to know how our sort of toolbox of clear cell tools applies to papillary and to chromophobe and to others. And in that degree, the B61 study I thought was really well done and really helpful, and for me at least, practice changing. So this meeting is special because it's the 20th anniversary of the ASCO Genitourinary Symposium, and I think both the data presented and the sessions that we had really serve to highlight how far we've come in the last 20 years. We did it by working together, we did it by having patients trust us and enroll in these trials, and the results we're seeing in terms of real tangible results, helping patients live longer and live better. It's a great time to be a GU medical oncologist, and I look forward to the next 20 years.